So it's been a longish road, all 7 sessions this summer on how to plan a CME CE.
Not to cut you off, but you'll notice on your desk, on your table here, I have a pre and a post-session questionnaire. So as we are beginning our preliminary, I didn't need to.
Yeah, that's great. Maybe we should take a few minutes for them to do that.
And it would only take that long. So
Yeah.
the pre on one side and the post on the other, obviously. So there's a chance. Notice the scale goes left to right. And so your first response is just the best. And this is anonymous, no question about that. Just take a moment to consider each of those items. Complete them would be a grand activity. Thank you. Okay, I think it's probably a good time.
Okay. Whoops, what just happened? Okay, I think you guys all know who we are. We have nothing to disclose, and we're going to, as usual, spend about 30 minutes on lecture and then some workshop activity exercises. Today's learning objectives are be able to describe Moore's levels of learning outcomes and their use in grant funding awards decisions. The pre-reading was the seminal article by Donald Moore that proposed this 7-level outcomes pyramid. So that's a useful resource for you to refer to in future. We'd like you to be able to classify common assessment instruments that we use for measuring Moore's levels and be able to identify what levels they'll hit, as well as identifying opportunities for evaluating CPE instruction, use concepts of evaluation for implementing curriculum change, and Jack will introduce to you the logic model of evaluation, and how to design a comprehensive outcomes measurement strategy for some of the more common formats. So just want to review, we touched on this back in session 2 in writing learning objectives, the concept of alignment and why it's important. You want to align your learning objectives with your instructional methods and strategies and with how you test, the assessment piece. If those are not aligned, if they're not all emphasizing the same learning objectives and methods, students can feel that a test had nothing to do with what they were taught. Instructors can feel that, yeah, we're testing and people are getting good marks on a test, but they are not showing mastery in the field. So those are common symptoms of a non-aligned set of objectives, assessments, and methods. We also talked a few sessions back about the learning contract so people know what they're getting. We don't want to false advertise. I'll turn this over to Jack for the evaluation piece.
So just a couple of common definitions here, and I guess what you might say basic understanding.
So when we evaluate an educational program, much like evaluating anything, it's what's the purpose? To find out if we met our intended goals, right? Worthiness would come to mind. And so be it our curriculum or whatever. We ask, what needs to be measured? So what are the things, so I can just open to you. So when we do a continuing professional education CME conference or a workshop or whatever that it is, what are some of the, what things can we measure? What things are, I guess, quantifiable? Well, even more, that's a great one, Dan, but more basically, number of people that attend, right? I mean, I know that sounds, but that's an important thing. You're selling Starbucks coffee. I mean, you want to know what your sales are, right? And your sales depend upon traffic, and so the same kind of thing. So numbers there. Outcomes, definitely that. How might you measure outcomes?
Patient safety.
Well, but you need some metrics, right? Some measurement. So even, and I just give one. So my pre-post is one attempt at even doing some of that, right? So at the end of the session today, so we have some of your preconceived knowledge and concepts about what evaluation is, the intervention that we have, if you wish to call it that, and then there's the post-intervention to see hopefully there's a change in that. So outcomes. So what other factors determine a successful learning activity CME program?
Was the information brought across to the right people?
Yeah. So it's a right audience, and some of that would come out to maybe a survey you could do afterwards and those kind of things. How about just plain old dollars? So I remember last time I think we looked at the cost and factoring in expenses and those kind of things. So those are measurable, right? Because you know that it costs, say, $5,000, $10,000, $20,000, whatever it is, to get everything organized and done. Okay. So just a cost analysis. So there's many things that we would look at, and bringing about change. Okay. So be it in perhaps sports medicine or some other opportunity, looking at what are some of the outcomes that changes practice, because that's what this is about. So we're doing anything that we wind up doing educational, hopefully, not just people, oh, well, I'm aware of something, I know something, but what can I do? What can I perform? So being able to treat patients more ethically, or using some practice guidelines or whatever that it is. Who are some of the key stakeholders when we put on a program like this?
Clinicians.
Yeah, well, clinicians for sure, because that's our target audience, for gosh sakes. Those are the people we want to impact.
Patients.
Perhaps patients too, if they attend, and we sometimes do that. The faculty we hire, if you wish to call it that are our speakers, right? Those are stakeholders. Different academic departments or clinical departments.
Hospital administration.
You look at administration. I mean, there are some of the vendors, some of the grantors, okay, that provide funds for these kind of things. The pharmaceuticals, if they are, as another example. There's a plethora of stakeholders that really, accrediting agency, right? Isn't that a big one? So when you put on a program of any kind, it has to be accredited with what the standards that we're meeting so that we can actually give people the appropriate credit for what they're trying to earn. So there's a number of systems that could actually allow us then to measure some of these, but it's important to know what are the components. So some common definitions here. So what is a program? Well, as we know, it's an educational event or activity. We think about evaluation, so it's always this, I'm not saying it's a moot point, but the difference between assessment and evaluation. We think of assessment, it's really kind of more formative, and it's kind of something we do during, so it might be, even my little pre-post here, might be an assessment tool. An evaluation is something that is more higher ordered. Sam, soon to be Dr. Taveras, will be getting his medical science degree and becoming licensed at some point. Okay, how does he get there? He gets there because of the fact that he's taken all the requisite courses and have passed the courses and passed all of the, just like anything else that we've done in our own profession, right? So it's really to say that, put that stamp on it, okay? Stamp of approval. And you don't get there until you go to the end, and it's based upon. So that's really kind of the evaluation. But once again, it's past judgment, worthiness. So how do we know that our CME course was evaluated well? Well, we look at all these factors, and you'll get a chance to do that in a little bit. So anyway, program evaluation is a systematic approach, no question about that. We want to make sure that we use proper methods for that. More summative as opposed to formative. So it's a process for judging, and that's the thing. It involves the stakeholders. So if we do an evaluation of an educational program, wouldn't it be good to get input from all of the stakeholders or representatives of stakeholders, the attendees for sure, the vendors, the accrediting agency, all these. So we get sort of a holistic approach. Just getting it from the learners tells us one part of the picture, but that's not the only thing. So the difference between formative and summative, I think I just mentioned that here. So the formative part is really kind of ongoing. It's sort of like what we use in education. We use feedback. So we're giving feedback. So that's more formative. But the summative part is really kind of at the end of instructions and determines the merit or worthiness. So think of any course that you've ever taken that's a prerequisite for the next one. You can't take the next course. I couldn't take organic chemistry way back in the day unless I passed general chemistry, right? I mean, it's all these kind of things. And so it's really, and you don't get a college degree, you don't get a PhD or an MD degree without going through that process. So anyway. So why do we evaluate any course? I'm proposing to you. We've touched on some things here already. Right? So you as the course director or the CME director for a particular course, activity director, how would you care about evaluating it?
To see if it's effective.
Okay. We don't want to feel good, right? That we've done something worthwhile if nothing else.
Yeah.
That's exactly it. And so, for that. But it's also for accrediting, too. It's really an important thing. But by the same token, so we have a team of people that put these things on, and we want to make sure that collectively that we've been successful. So who's to say that catering, it's not the highest order thing, but still they're part of the team in some respect. Not that they're so important in the outcome, but they are to some extent because we get on the evaluation forms, right? Were you satisfied with, and if you remember some of the steps that we've gone through, like Moore's in particular, so satisfied, was the room environment, was the food, these things play a role in what we do. So some of the information that you gather, we've just talked about some of those things. Who are some of the stakeholders? What are some of the challenges in evaluating? What are some of the challenges that you've encountered or think that you might encounter when you're doing a assessment or evaluation of a CME course?
Like a time?
Time for what? Time to actually go through some of the process, perhaps? Okay. And time, yeah, and timeliness too, because if you wait 6 months to evaluate, what's the downside about waiting too long to reflect on the value of an educational program? Yeah, pretty much that. You forget, the enthusiasm is gone. You're on to the next thing. You're fumbling around trying to find any kind of data sources that you can find, if there are any at this point. If you were to do a post-session follow-up with your learners, they might have forgotten, gee, what was that conference I went to back? Oh, yeah. Oh, the food was good. I can't remember much of the, whatever it is, it wouldn't be very positive. So I think those are some of the barriers. And some of the methods that we use to collect, too. So we oftentimes think about surveys as one thing. And it makes for an improved course, and that's the whole point in wanting to do that. So the next one we do, and the more of this that you wind up doing. So always think about what is the purpose and the mission of our, and it's kind of the goal. So what is the goal when we're putting on a CME course? So we have our learning objectives, but the goal is to impart knowledge or skills on a particular subject. Just, it could be like we just did recently, urology as an example, quality improvement, because it has some overarching goal that we're trying to do. It's not just the day of the event, but how it ties into the overall purpose of the organization. Do we need to identify somebody who's responsible for the evaluation at the beginning? Wouldn't that be a good thing? So it typically falls on the activity director, I think, to some extent, but it was still delegated to one of the team members to do that, and somebody who might feel more skilled, because somebody needs to be responsible in how you go about collecting that data. And it's important to set those expectations early on.
Would it ever fall into the CME office?
Well, yeah, like everything could fall on Peter's shoulders eventually, but we don't want that. So the whole thing about being self-directed, okay, and doing all of this, that you use all these tools that we've had these 6 weeks, is to be able to do that. And so regularly examine the system that we have, the methodology that we have for collecting information. So here's one model. There are a number of them out there. And this is one that I propose, and you'll have an activity in just a few minutes to actually complete part of this. That's what's called the logic model. And one of the things I like about it, if others, Joe, I don't know if you've ever seen anything like this before. What I like about it is that it's linear. And so we think about our own thinking processes in medicine. We're kind of, a logical positivist, but the point is that A equals B equals C, so there's sort of a linear component to this. And you think about that too. So you're starting with the inputs and you're looking for outcomes, okay, and everything in between, and how you go through doing that. And we'll have an activity here coming up that gets you through some of that process to think about how this might tie together and make for something that provides you with some worthwhile outcome measurements that you can say that, as opposed to, oh, everything was good, people had a good time. Well, that's lovely, but you want something more than that. And not only just for accreditation, but for your own satisfaction too. So over on the far right is kind of the long term, the impacts. We'll look at that. There's some real challenges there going through that. So anyway, the basic framework for an evaluation is think about the perspectives, the people are involved, examination of the data that you have, accessibility of information, feasibility. The propriety part, thinking about some of the ethical issues and legal issues about asking questions, getting information, and ultimately the accuracy. So how accurate is that information that really tells us? So sometimes we have independent evaluators, which is probably a good thing, right? Because what's the value in having an independent evaluator of an educational program? Yeah, that's objectivity. So I've done a fair amount in my career, but I use the same tool regardless of what the subject matter is. And so have no vested, real, of course I get paid, but do have a vested interest in a sense, I suppose, but still being able to use some of these strategies. So. Okay, so this really has a lot to do with quality improvement, and Rob will guide us through this part.
So we talked about stakeholders, some of whom maybe the people that fund the continuing education by giving grants. What do they value? There's a common misconception that they're giving them money from a commercial standpoint, hoping to gain something in the marketplace, such as increased sales because the continuing ed emphasized their drug. And really that has been chased out of accredited education starting about 10 years ago. What we're seeing is that even among pharma, the grants committees are thinking like public health researchers. They want to see gains in health outcomes, changes in patient health. For them to give philanthropy and get it from the government to get a tax break for it, it can't be traceable in any sense to their sales bottom line. And so they are now avowedly thinking like public health researchers and more often now making people who apply for grants compete with each other head to head based on how good the outcomes they can achieve and the reporting of those outcomes. So everyone wants to see education that's effective at improving care. The IHI, for those of you who know, the Institute for Health Improvement, is a great resource for tools and frameworks, ways to think about the triple aim, which even federal government Centers for Medicare and Medicaid is embracing, that we want to try to improve all three on an ongoing basis: population health, satisfaction of patients' experience of care, and to lower cost. So that's the triple aim. Interestingly, our Dean for Graduate Medical Education a few weeks ago referred to the quadruple aim, which is that physicians, the work-life balance and the work rotation schedules increasingly is hard on them, and that's a potential quadruple aim to really not injure our caregivers in the workplace because they're too tired or overstretched. So we'll get into Moore's pyramid in the pre-reading, but let's talk about some of what Jack referred to. What do we mean by effective at improving care? What are we trying to measure? Does anyone have a gut reaction to this? What basic things about care improvement can we measure? Anyone know where we'd start? Think about who receives the care.
Patient satisfaction.
Patient satisfaction, that's a good place to start. Patient.
How about from a clinical standpoint? How about diagnostic skills? Sports medicine, really, you pick anything. So better diagnosis leads to better treatment, perhaps. Better outcomes. More accurately,
Recovery.
Occurrences, incidents, also the cost of care. If we look back here, if mistakes create additional cost. So, and we saw this a few weeks back for those of you who were here for some of the earlier sessions. Donald Moore proposed expanding the outcomes criteria to what he calls 7, but it's really 8. Participant demographics is the bottom line. It's how many people signed in on the sign-in sheet, how many people came. Number 2 is how did the participants feel, the satisfaction level with the food, the instructors, the overall use of the time. And then 3, we commonly think of as 3A and 3B, didactic knowledge. Can you explain the mechanism of action of a drug, versus procedural, which is, do you know how to insert a central line? And then there's even talk of 3C, which is adopting appropriate attitudes, values, behaviors, maybe even ethics around the new knowledge that you're getting. Oops. Competence is taking that one step farther. Can you demonstrate that you can do it? So we just showed you, and you know how to do it. Now do it for someone, maybe in an OSCE or some other simulation test. Show competence, and competence means faithfulness of execution of the skill. Usually not with the patient present, but in some sort of test environment. Performance would be doing it in the clinic. with the patient present or in the actual workplace. Harder to get this information. Generally, the educator doesn't directly get the job performance data, unless you work for a big institution that maybe can gather that through the electronic health record. Winthrop is not there yet, possibly could be at a later date. And then level 6 is the patient health. Did you actually improve health, quality of life, prevent disease or sickness or injury? Level 7 is the patient health across a broader group, community health, and community can be either bounded by a demographic sense of Nassau County, or it can be a community of diagnosis. So all those patients with inflammatory bowel disease could be a community. So 7 is the hardest data to actually measure and get. It also, as Jack showed in the logic model, is a longer term outcome. Generally, you need more time to gather and aggregate that data.
One of the biggest initiatives, we talked about this before, is sepsis prevention in the hospital. So such simple things as hand washing, but eventually, leads to things like readmission. To say nothing, septic shock and death and those kind of things. But still, so there's some real impacts that go along that whole trajectory, going from not only knowing what the different microbes are, the different types of strategies that we use for prevention, but then the whole thing about actually putting that into practice, hand washing, that goes along with controlling contamination across patients, up to readmissions and illness and disease.
Yeah.
And at the community level too, because we can actually measure this throughout Nassau County, I think, to some extent.
And CMS, Medicare, Medicaid, and many insurance providers can aggregate the billing data, diagnostic codes,
Right, oh, sure.
get that at a community health level that maybe the institution can't get
If your
on its
sepsis
own.
rates are high, you're not going to get reimbursed for.
Right. So pop quiz. Everybody ready? Buckle in, buckle up. Give me an example of a more level 1 participation measure. How do we measure participation, Sam?
Just looking to see who signed in.
Good. Did they sign in, sign up, attend, or click if it's an online thing? Satisfaction level. Peter.
Did they complete a evaluation survey of any kind?
Good. And or provide any other feedback. For example, they may tell you, great course in the hallway.
Like catering side?
Yeah, and that is, satisfaction is definitely an evaluation, not a assessment, because it's really feedback to the educators on how the educators did, not how the learner did, which is more in the assessment area. Didactic knowledge change, how would we measure that, Diana?
Test what they learned, what they took from it.
Good.
Yeah, like a quiz.
Yeah.
Yeah.
And in fact, procedural and attitude values change all might use a similar set of instruments. A choice of a quiz, a pre and a post test. Why would we use a pre and a post, Joe?
So you can actually trend actual items that they did improve upon.
Exactly. Exactly.
Statements.
Start with a baseline for each learner and measure each learner's improvement, as opposed to averaging and aggregating the group. You may lose some of the signal in the noise there.
And look at procedural knowledge, thinking of our esophageal endoscopy course as an example. To perform this probably better, and we could follow up at some point to see if they're actually using those skills. So that's definitely procedural.
That's a great example. Yeah. Okay, continuing our pop quiz. Change in competence. What's an example of how we would measure change in competence?
either a simulation or some kind of testing, like a simulation setup or an OSCE setup.
Very good. Or preceptorship. Change in performance. Example, how would we measure that? How could you measure that?
How about self-disclosure of that count, or self-assessment?
Subjective self-report,
Oh, there you go.
chart review, chart audit. Higher powered tools, but it is being done out there in the world.
Labor intensive.
Labor intensive, research intensive. Change in patient health, how would we measure that?
Things like electronic record review, like diagnoses and infection rates.
Exactly. CMS scores, quality improvement projects. And how about a change in population health?
Wouldn't it be similar, but just like a broader
Yes.
range?
Chart audit, CMS scores, QA study project, aggregates from your healthcare IT system or insurers. Can Sorian eventually tell us that these cancers, show this set of outcomes by doing a database
One
search?
step further than oftentimes we think about drawing Sydney into our. So I was pointed earlier the whole subject of epidemiology, something that Joe knows about too. So epidemiological studies, looking at population health changes in an aggregate geographic, however big that you want to get, population
That's a great one.
would tell us that.
That's a great one. And that's drawing on maybe national data, national literature, large scale stuff. Okay, so when we're writing tests, I just want to put this caveat out there. Beware of survey taker exhaustion. Jack alluded to, what you can get from the learner and practical, what's feasible. You can only ask so many questions before you kind of lose the attention and goodwill. Or you may be asking questions that are so searching that it's making the learner self-conscious, and then it's maybe changing their ability to be objective about themselves, much like an unblinded study participant would be. Or they may just not have the time to
Or
do
they're so worried about their certificate that they just speed through it. I kid you not, because I get this, I've been in this for 4 years, and most of them just go through it, and all they're worried about is getting their certificate. They don't actually take the time to, our survey's not crazy long, but they just speed through it, and that's all they're worried about is getting their
That's the
certificate.
one with the gap, the questions with the gaps?
Mhm.
That's what I'm gonna be doing.
Yeah.
So that brings up a good issue for you all as planners. If you really need that data, try to give it, make your certificate conditional on an evaluation being completed. Because if something's optional and a lot of work, a lot of people will skip it, and that may bias the data you do get.
And
If you
that's
get
why
any.
we stopped, and like I said, this is even before Rob came in, we stopped giving out certificates the day of the meeting. Because half the people bail out right after lunch, and there's no motivation for them to fill out a survey. And then that screws us up because we're trying to look for data. So we started doing it about 2-3 years ago, where we tied it to, complete this, then you get your certificate. And that it seemed to have increased our data, which makes it easier and better for us.
The other thing is it provides an opportunity for the learner to use those evaluation and self-assessment questions to reinforce what they've learned. Commonly in CME surveys, we say at the end, what did you learn today? One thing that you're most likely to make a practice change with, and perhaps what's one that you're least likely. Those are actually continuing the education by sort of getting a commitment, a buy-in from the learner to actually go forward and make the practice change. And the least likely is to identify, to use some barriers. They may need help overcoming a barrier, a rule against making a change, not having the equipment. If you can elicit that information, it allows you to plan for the next cycle. How can we remove the barrier next year? So whenever possible with a survey, try to use technology to help you reduce the redundant data entry for the learner. I don't want to have to give my name every time. I don't want to have to tell you my specialty every time. If it's possible to automate, there are tool sets out there. I won't spend a lot of time on this, but increasingly handheld apps keep you logged in. And, once you're on the app, you don't have to give identifiers. And it's, it still gives that information to the survey. Consider what's going on with big data, as we mentioned Sorian, but also Facebook type apps. Everything you click is giving data to someone. How do we feel about that? Can we use that as educators? Can touchscreen apps tell us, for example, drag the piece of equipment on this picture over to the exam table, and maybe there are some that are correct and some that are incorrect. Those clicks can provide data. You can measure the order in which somebody touched the screen. So those tools are out there. They're not yet at Winthrop, but as a spur to maybe some creative and innovative thinking, maybe we're the generation that will begin to do those more sophisticated education interventions. And finally, all of this data, the scale of it has really changed social science. What maybe 25 years ago was thought of as less scientific or softer science than the hard sciences, because it was harder to get data, it was harder to get a large N in surveys. Now, increasingly, the data is flooding in through mobile devices. It's made social science more scientific because of the scale of the data. So, and I just want to touch on what's a fairly recent innovation. The patient-centered outcome research is a field of study that looks at involving patients in the design of research and in the delivery of healthcare and education, so that rather than sort of an authoritarian model of an expert designing research on subjects that may be blinded from it, maybe the patient has an important perspective to contribute in the design of research, especially as we're looking at how to change their satisfaction, their experience of care. Pfizer has recently begun soliciting grants that specifically look at those patient perceptions and patient experiences in understanding their disease, their health literacy around their diagnosis. And so that is something that's being funded. There's also now encouraging patient ambassadors to be on the planning committee of continuing education. Again, you want patients who are themselves very literate so that they are able to help you advance the conversation and not necessarily hold back a professional audience or make a professional audience feel that they can't be frank inside the classroom. You want a more sophisticated patient ambassador, such as the head of a patient disease organization, Crohn's and Colitis Foundation, or perhaps a nurse who has a diagnosis of the disease but works as a nurse. These are all great patient ambassadors. Patient advocacy groups can be your partners. If there's a hip replacement survivor or hip replacement society, perhaps they could be a partner in an orthopedic conference, co-sponsor. And a lot of what used to be ask your doctor about campaigns are now tell your doctor about your disease campaigns. You're seeing this more on TV, but it's really shifted the thinking that patients have a role in their own care. PCORI, which is an institute funded by the Obamacare legislation. Each one of us who has a health care plan, our health payer gives $2 a year for each of us into a national fund. And that is a grant fund for changes in research in patient-centered outcomes. So I've left a link for you there if you guys want to explore more about that. Their vision is that patients reflect their desired health outcomes and that they have a voice in guiding the research. So back to Jack.
So this should be quiz time here, if you recall from your pre-reading, because this is a flipped classroom model. It's also in one of the slides too, if you're really quick at doing this. which of these Moore's level is one to assess competence of a physician? Level 1, 2, 3, 4, 5, or 6. Let's get some responses here.
One.
Answer is 3. Maybe one more. We can squeeze it in somebody. There we go. Great. Now let's see. Okay. Maybe there is.
Reveal. 5 respond.
We'll close. Level 4. You're pre-reading. So once again, audience response, and you poll everywhere too is another strategy you can use this. And so it's a way, obviously, is to get assessment of people's knowledge. I want to ask the person who put level 3, only you know who you are. It's anonymous. So
What is level 3? Anybody?
it's in your handouts too. If you're
Knowledge change, procedural, declarative, or attitude. Level 4 is competence. You want to go to the next one back, or?
Yeah, let's keep on going. Okay, anybody have any questions or comments about evaluation and assessment, use of some of more levels for assessing outcomes? If not, Rob will conclude here with our culminating activities. So people work in pairs. I guess this is obviously you have natural pairs, and then 3 to 1. And I'll join you on it over here too. And so the exercise here is pretty much said here is think about using the logic model. So think of a hypothetical CME course. What are some of the inputs that you would need? What kind of things that you can identify as inputs? And there might be things like, and I'll just give you one example because there are many of them, but things like a budget. It's not going to happen unless you have funds to pay for it. But that's only one of the number of. And what are some of the activities that would be involved in putting together an educational program? What are some of the outputs? What are some of the short-term, long-term, and perhaps impacts at the end? So we've got 15 minutes, and we can all work together on this too. Perhaps the three of you, Dan, Sam, Peter, get together there. Ooh. Someone put a chair.
So is this his team?
So you got time, right?
Jack, can I go put the logic model on the screen? Somewhere here. Program resources, which can be
So the actual content. Yeah.
No, but that's a consideration. We need a planning committee, a team. We're not even teachers. They're just organizers. Just make sure you guys know.
what are some of the activities that would go into converting inputs?
So like the organizers from
Yeah. So if you have some inputs would be like
Section.
this course director, give you that responsibility. The maternal child health.
maternal females.
Okay. Certainly that would be.
Right.
To bring something on the very topic.
Close.
Needs assessment.
You have
Okay.
coordinator, maybe let's tackle it into word two.
Followed by ready of a set of
Learning objectives.
Yes, some of that.
Logistics.
I'm getting excommunicated. Maybe let these guys turn. What else? Planning out
So the inputs.
time.
So let's say you have something.
What else? What are some of the other artifacts that you create?
Time.
Processes that you
The fact that, so what, 2 weeks from now? 6 months from now?
Evaluation.
So it-
Evaluation survey.
you know, the writing of it.
Yeah.
At least 6 months.
We do ours now, we do it every month.
Yeah,
Defining the outcomes.
but that's continuing.
Mhm.
I just think
Yeah,
that's
writing
something
outcomes.
that-
A
Strategy.
one-year kind of thing.
Yeah, so many of the big symposiums.
You
that
even
we have
say
and stuff.
things like
So,
the learning methods, which would first section, the choice between how furniture can really affect people feel more collaborative versus competitive versus tuned out in the back of the room with microphone versus involved. That box is probably not big enough for everything.
How you think that how would that be to inflect
Am I right?
changes?
So what are some of the outputs?
Clinical stuff, what are we doing? Presentations?
Getting the audience in, delivering the activity, the actual day of the show.
And interactive on
These are all the outputs. Building a course binder to give away. Putting it within.
What about the exhibitors? Could the exhibitors be
Just getting,
listed as
getting
output?
the speakers,
What's their relationship to the learning process?
how we use it.
Okay.
I'm just in my head, I'm just thinking.
Yeah, no, they're not.
I mean, maybe they
They're not supposed, well, they're not always supposed to.
Maybe somebody outside.
Yeah, I would put them sort of on a dotted line off on it. Although getting them to sign on definitely volunteer because it gives you what
Our research.
gives you something in this.
And research day. We had speakers next year already. So a lot of activity.
So, Dan, let's take the course that you're developing currently. What are some of the short-term outcomes that we
See, look at what is going on.
short capture?
So, you have, let's just say a one day.
We plan on doing hands-on stuff, so obviously clinical.
And just your basic knowledge. Walk out in knowing what it is.
Are you having scorecards or something with the faculty assessing them?
Why don't you open the doors, right?
Self-assessing their comfort level?
I guess it would be self-assessment.
Yeah, people register. You got 100 people registered. It's time to start.
Would you consider that a formative or a sign?
The weather's good, the train's running, the element is wide open, no problem there. So maybe we didn't mark it.
You could actually do either. I would tend towards summative.
Short
If you do it halfway through the class, that's
Good
more
part.
informative, and then do one at the end.
Comfort.
Anything that's a practice test is generally
satisfaction.
formative.
If you're measuring that at the end, it's good.
A midterm that doesn't count for credit is formative.
Safe.
And then long-term outcomes. What do you hope would come out of your
Patient quality, patient care.
and how would you fix the evidence for that? How would you collect that?
That has to be like a long-term.
Evaluations
Evaluations then, down the road in 6 months.
I'm trying to look through the little.
Yeah, it's, it definitely takes more thought,
Or a party planner.
long-term,
It ain't much difference, right?
consultative thinking.
I like long.
What can you collect, what can you capture? The occurrence of certain
I
injuries,
would add one, long-term.
prevention, after,
So,
Let's go to the attendance first.
I mean, maybe prevention.
Well, yeah, that's
First
what I
injury
mean.
of all.
To improve patient care, you have to have an attending physician.
So there's two things that I'm not declaring.
First responder, doing the right things as opposed to maybe missing a couple of steps.
And for
Skill, which,
Well, they saw a skill. Actually, so maybe, I'm not sure what the procedure is going to teach and convey, but I would say
it gets close to the Moore's level 7 or change in a larger community that is you know, in a hopefully very measurable way. Things like that.
So how would we now
Premature births in the maternity unit went down, testing for preeclampsia more routinely, and they went down by X%, and that's a document something to factor that's measured.
I'll send you my son.
Anything like that, that's works.
Sure. But I mean, you can look at, it's unfortunate, it's a bias.
Yeah.
They see up there, so
Show off. Jack, I'm so sure I'm females. Show off with my.
You go back to last year,
But whatever it is.
blood, fuel,
Body,
body,
long term.
and look at maybe prevention aspects. A year later, or, you know, is what people learned that that's supposed to be changing incidents. and
possibly, I mean, we did,
How are we gonna know?
I mean, we did the cardiovascular portion, so they could have.
Maybe it's something that we use.
You know, screening.
The
year
screen
later.
and we
6 months after
can
that.
see the volume, how many you have done.
And another one,
Yeah,
another
that's good.
Look at sheer numbers.
changing patient literacy. We don't directly do that in professional education, so we're educating educators
We can't say it's the one that
who
conquers.
actually are teaching the patients in clinical encounter.
Nothing else.
And maybe they're raising patients' literacy about
So that could be.
ACL tear, or about A1C measure, cancer risk. Patient literacy or illiteracy, health literacy is a big driver in healthcare, costs and consumption of healthcare. And if you can raise patient literacy even a little bit,
What could be a satisfaction?
Yeah.
But then I think
their use of healthcare resources and their need for critical care resources. Peter, do you have a upcoming symposium that you want to take through these steps and think about how to maybe better address some of the
week after the conference, where people learn the process. What do we do in this one?
I'm sure there could be from inputs to impact is what you're.
Yeah. Do you have any maybe less than ideal symposia that maybe miss some of these stages or don't think about?
Your role, you know, how was my role? You know,
Clean up in any of these areas.
Joe,
More denting for me.
for this, next time we mention.
That's it's a renal
Yeah.
renal cancer.
Whatever it is.
A lack of input, a lack of activity, a lack of output.
I think it's a.
All these things, but it's good to meet with the team afterwards, at least they have something.
I think it's a lack of activity, like an outcome strategy, or writing the eval survey. I mean, the writing outcome strategy. Because honestly, I don't think they've ever really come up with that. With outcomes.
Was it a worthy event?
So I think it's more lack of activity.
Conference.
Um,
To achieve the goals that we had in mind.
Lack of, content. So in the input category, because all
Yeah,
you
I was
get
just,
is
I was just
You
thinking.
can't expect it, you know, I mean,
there's not a lot of content, there's
it's
just
impeccable,
one keynote speaker.
you know.
Right.
It's almost like, it sounds like they have an output they have in mind.
Right.
They don't know how to get there.
Right.
Or they put in cart before the horse.
I think.
Right.
Because it makes sense that there's professionals that will do it. in
It's
sync.
kind of a holistic
Yeah.
approach to it.
Sam, do you have any continuing education project that you are thinking of doing? You would want to maybe design?
Yes, identify a competence
And
gap and a professional
Nothing
gap.
that's been formed, but
I could see it,
I think it's interesting of, it's from the medical education standpoint.
I think I know.
Knowing the anesthesia.
Because I guess they would write it down.
The simulation sector, activities more, for education purposes, and so,
Yeah. Right.
you know, looking at the short-term and long-term outcomes of more competent physicians who, you know, less infection rates, you know, things centralizing and things like that, so.
We could just add in an input to our list that we didn't have before. Simulation gear,
Oh, yeah.
that's an input. And what's the output or something?
Having the actual session where you have, you know, somebody running the mannequin codes and all that.
Maybe an OSCE.
Yeah, an OSCE.
Okay, everyone, I hope that was good,
Anybody
good
want to
practice
report out
session.
any significant findings? Lori has a very fundamental, yet very important question. Maybe Peter can answer that.
Me?
Diana?
Hang on, sorry.
Okay, no, I apologize.
Peter was explaining about the surveys after the CME. What's the difference between a competence gap and a professional?
Performance gap? Level 4, level 3?
The professional, I can't.
Oh, a professional practice gap?
Yes.
It's this, a practice gap and a performance gap are the same, really.
Okay.
Practice is performance, so it's maybe just alternate wording that's confusing.
I can't remember word for word.
Whatever
Yeah.
knowledge gap, is that
That
what
is
you-
a knowledge
Oh.
gap
Yeah.
and a professional.
Yeah, so let's just take a brief look back at Moore's. A knowledge gap is actually level 3. Knowledge change and a change in competence is a test, a demonstration. Performance is what they do in the clinic. So usually a needs assessment is looking at, some shortfalls that are happening in the clinic. We can document, and that's part of the need. And maybe you can trace it back to people aren't aware that there's a risk of XYZ, and that's why this is happening. And that lack of awareness is a knowledge gap. So it's generally the desired state of affairs and what's the current state of affairs. There's a difference. That's the gap.
My bad example, but you get the idea.
Yeah, no. I'll remember it.
All right, well, I think-
Good, good question. Anyone else? Oops. Did you want to
yeah, well,
go here?
can you go back? Oh, yeah.
Here?
So the polling is open, so, see how well you are with Moore. So level 3 measures what? Performance, participation, learning, reaction. Okay.
The majority is correct here.
And actually you have the correct indicator, so you go to the next step. There.
Yeah. Good animation, Jack. And performance is what more level instead of 3? It's competence is 4. And the clinic is 5. Performance, exactly.
So, speak for Roger. So we have our closed session questionnaire if you want to complete that. So this concludes, Roger.
Yes, it does conclude the series. You all are proud graduates, at least those of you who attended every session. But you get a certificate for every session you attended. Thank you all for being a part of this. It's been a great experience for me.
What did you find most useful either today or for the whole survey? And don't tell me nothing. Either. Dan, what was
I think the whole course helped me because when I did my first one 2 years ago, I had no clue. I think everyone did it for me, and I was just kind of getting things together. And now this year, I've kind of come up, with the objectives and the goals, and I've seen the whole process. So I think, the whole thing was very helpful too.
I like the Moore's pyramid of the outcomes. Kind of like breaks it down into a nice, I don't know, it just makes sense, intuitive sense.
Like the methodical nature of it, I like that.
It is very scientific
Yeah.
at root. And one of our overall goals was to really grow you all into thinking of yourselves as educators. I hope we've done that. I think of you as educators, no matter what level you're at or what side of the practice you come in from. We all have to self-educate to stay in our profession.
And especially as being course directors, organizers. About all the factors and features that go into putting on CME activity programs and accreditation goes along with comprehensive approach to what it takes to do that. And as a model for others, Peter and Rob are a wonderful two-person team, but with the added demands on doing this, the more self-directed people are, and self-directed in the broadest sense is what we want.
Yeah.
And you can model that for others too.
Yeah.
Well, you can.
We do want to get these sessions into some sort of form for the web, and that way you'll have them to refer to on an ongoing basis. But if you haven't seen the current modules we have that Jack recorded a little while ago, they're excellent, and they can be a good refresher to everything we covered this summer. They're online.
Yeah, so the instructional design, each of those are about 8 minutes, not very long. So it goes back to session 2 or 3, whichever one we.
So that's it. We'll email you a survey and maybe the slides also. And enjoy the rest of your summer. Thank you all.
Thank you so much for putting this together.
Oh,
Very
a pleasure. A real pleasure.
Sam and Sydney, do you guys need a certificate of completion? Because we can write it.
Not hard.
Good luck.
Yeah, put that in your CV. Well, you could. No, you might have to. Yeah, residency programs, right? Good for residency.
Yeah, I guess.
Probably, we're still discussing that. We've gotten some pushback on what's the appropriate time of day. I'd love to do it in the last half of August, but maybe it'll fall later in September. We'll keep you posted, absolutely. Thanks, Jim.
Thank you. Yeah, thanks for helping Sydney out.
That's great. I'm glad it's working out. Yeah, good luck to you.
Are you all squared away or anything good finally?
Yeah, I got what I needed, so maybe I could go